Hello, welcome to the PaedsHub Pod. This episode was recorded in front of a live audience at the 2023 RCPCH Conference. Thank you to the Royal College of Paediatrics and Child Health Events team and the Scottish Events Campus teams for their support. We hope you enjoy this episode.
Good morning and welcome to the PaedsHub Podcast, live from the RCPCH Annual Conference. My name's Leila.
And I'm Felicity.
And we're paediatric trainees based in the Southwest and members of the PaedsHub Pod team. We're delighted to welcome today our expert panel to explore what the role could be of the paediatric ward in caring for children and young people with a mental health presentation. So we have Dr. Anna Kyle, who is a consultant general paediatrician and the clinical lead for mental health and eating disorders at Musgrove Park Hospital in Somerset. We have Dr. Elaine Lockhart, who has over 20 years experience as a consultant psychiatrist with the Liaison team and is currently the chair of the RCPsych Children and Adolescent faculty and works with young people with learning disabilities. And we have Dr. Lee Hudson, who is a clinical associate professor and honorary paediatric consultant and the principal investigator for the MAPS study.
So we're now going to start our conversation by thinking about the current state of play. So Lee, could you please give us an overview of what research tells us about mental health admissions to the paediatric wards?
Okay, I think the first thing to say is that this is not a new problem or issue. People who've done paediatrics for a bit longer than each other will be able to tell you that there have always been patients who have been admitted to children's wards, to general children's wards, particularly in mental health crisis. I think the difference and the challenge now is the large numbers of people that are presenting. And that's incredibly variable across the country. I think from a research perspective, and as a researcher that researches this area, there's very little evidence actually. So that's the MAP study, which we're going to talk about. It's a starting point, I think, in the UK. But if you look throughout literature, and we've recently done a systematic review on this as part of our research, very few studies have actually published on numbers and what the challenges are.
And you mentioned the MAP study there, which you're involved in. Do you mind briefly telling us a little bit more about that?
Sure. So the MAP study is Mental Health Admissions to Paediatric Ward study. It's an NIHR-funded study that started in earnest in June last year, and it's got some bold aims to look at the problem across England, because it's an NIHR-funded study, which looks at total numbers across in the last 5 years of admissions using existing data that hospitals provide to the NHS, but to have a more granular look at the kind of things that are happening during admissions and numbers from certain centres, and then importantly a qualitative component that's going to be interviewing not just young people and their parents, but also their families and also the staff that work on the ward. So really trying to go from the top down to the bottom to understand. And it's unfortunate that we're in a position where we're not going to be coming up with radical solutions at this point, because actually there's very little data on what the problems are. I think most people would say they know what they are, but the challenge is to actually get that down and understand it so that you can approach changes in an evidence-based way.
So Anna, I would like to come to you and ask, what do you think the role of the general paediatric ward could be in caring for young people admitted with a mental health presentation, and what do you think some of the barriers are to delivering this care?
So I guess the first question is not necessarily what is the role, but can the paediatric ward deliver good mental health care? That's the first question, isn't it? And I suspect you've got me sitting here because you might have a sneaky idea of what my answer to that is, which is absolutely. I firmly believe that the paediatric ward can deliver really good mental health care, and it can be a therapeutic environment, and it needs to be. And I think we were talking about this earlier, there is variation across the country, but there are increasingly large pockets of areas that are doing it really well. And I think if you come back to that age-old question that many of us will have been asked about, why are you a paediatrician? What's your goal? What are your aims? What's your mission statement? That many of us will have been asked, interviews or on application forms for, ST1 or in the school playgrounds. And I think most of our answers will be something along the lines of, perhaps not as cringy as this, but something along the lines of, I've become a paediatrician because I really want to help children and young people to thrive, to flourish, to achieve their goals and to be happy, functional, successful adults. And I'm going to do that as a paediatrician by supporting their health. and health is mental health and physical health. So I think no longer can we as paediatricians bury our head in the sand and say, no, we don't do mental health, that's not for us. You know, our specialty is physical health. That's not the case anymore. And I think we've got COVID to thank for some, you know, we haven't got a lot to thank for COVID, but what we have got to thank is you know, we have seen, and some people describe it fairly dramatically as this sort of tsunami of presentations to our paediatric wards of children with mental health difficulties. But what that has done is shone the light on this area that there absolutely needs to be change, and it's really been an amazing catalyst, an amazing catapult, and I think we've seen huge changes just in the last couple of years, and it's been amazing being at this conference and just seeing the amount of chat there is about mental health, and there's a real buzz and there's a real desire, and you know, there's increasing numbers of paediatricians who really, really want to see this change and practice change. So yes, the paediatric wards can deliver good mental health care. Yes, there are barriers and challenges, and I think probably the biggest challenge is how do we support this ongoing need for a change in culture, a mind shift that this is our business, and we can't be relying on psychiatry colleagues. You were saying, what, there are 10 times more paediatricians than psychiatrists?
Apparently, between 9 to 10 times more paediatricians than psychiatrists in the UK, yeah.
We have had some reflections from our nursing colleagues, and some of the key themes that have come from that are a sense of fear around looking after those young people who might need repeated restraints for NG feeds, thinking about individuals' experiences and the training that they may have with this, and the effects that this may have with limited capacity in the medical team, the nursing team on the ward, how that may impact other young people who are there. And Elaine, I'd love to come to you and ask what you would say to these colleagues of ours who have these experiences, these feelings, and who may suggest that a Tier 4 unit is able to give a better quality care for these young people.
Thank you. And I guess going back to the initial poem talking about that trauma of being restrained, and when I think back to the playground or whenever we decided to be doctors and to work with children, nobody signed up for that. And I think you'd say the same about our paediatric colleagues within any setting, whether it's mental health or paediatric wards. So it's really traumatic for everybody involved. And also, I completely recognise what this paediatric nurse is saying, because we're saying, okay, yes, we can do this and we should be thinking about children holistically, but we haven't had the training. I mean, paediatric nurses generally have had the focus on physical health care. We've done some training in the Children's Hospital in Glasgow when they start in the hospital, and I asked a huge group of newly qualified paediatric nurses who had training about depression. No one had had any teaching on depression. Now, you know how common depression is. And the same in medicine. You might get 5 weeks as an undergraduate student. So I think it's very reasonable for people to say, this is not our business, we're not trained to do it, we can't do it well, and we're traumatizing children. And we can't really get past that unless we really change what's provided in terms of training and support for anyone who's looking after children and young people. And yesterday in the plenary session, we had a really excellent presentation about kindness, and actually about the effectiveness of kindness. There's an evidence base. And I always think about the best form of kindness clinically is informed kindness. It's not just enough to really want to be helpful. You really have to have that backed up by having had training and support, knowing what you're doing, knowing how to get help from other people if you need it, knowing how the system works. So there's a lot we can do, but I think how these paediatric nurses are feeling and other colleagues are feeling is entirely understandable. And the tsunami did catch us unawares. There always have been a certain number, but in our hospital we would have had maybe 4 or 5 children coming in every year on an eating disorder care pathway that went up for about 2 weeks. And then by the time COVID struck, we had 5 children in the hospital in the same month. Now, we were all on our knees, but it just shows you that surge in demand, and it's been difficult for all of us.
So we've got on the screen a joint statement that was released in December 2021 by the Royal College of Paediatric Child Health, the RCPsych, and the Royal College of Emergency Medicine, which brings together the collaborative nature and as you say, Elaine, that they need to work together. So perhaps, Lee, we could come to you and ask from a paediatrician who's looking after these young people day in, day out, what do you think the needs are for the general paediatric ward environment from our CAMS colleagues, our psychiatry colleagues, in delivering the best care possible for these young people?
Yeah, I mean, I just add that, this is not a problem that's going to go away. This is the epidemiology of child health. We've done a fantastic job, not us necessarily, but generations before us, at tackling sepsis. Vaccination has meant that the number of cases of, for example, meningococcal septicemia is massively reduced compared to when I first started as a paediatrician. It still happens, and sepsis happens too often, so I'm not saying, but proportionately, if you look out epidemiologically in the community, the reason that children and young people need our help, one, it's long-standing conditions, two, it's safeguarding and child protection, and three, it's mental health. And if you're to look at what the bigger killers are of children in the last 10 years, that's hugely shifted. So in a sense, nature's a fickle mistress. She will constantly find reasons that people become unwell, and every time we solve one challenge, we'll have another one. That's always been the nature of the game of medicine. That's a tricky thing to say, but actually we've just got to face up to it. It's not going to go away. And there are really good examples that I've mentioned about how we've looked after other illnesses and got them better. If we were having this conversation in Glasgow in 1945 at the end of the Second World War, people would have thought that cancer was untreatable. So in 1945 and 1950, if you got leukemia as a child, it was a death sentence. There were no treatments. Cystic fibrosis, hugely limited life. Diabetes, hugely limited life. And it was an expectation, which is probably the wrong word, but I'm going to use it anyway, that if you had a number of children, one of them would get very unwell under the age of 5. And thankfully, that's shifted. And actually, the reality is that you are more likely to die when you're 13 or 14 than you are when you're 3 now. So I'm just going to say that again, because that's a really unique time we live in. You are more likely to die now at 14 and 15 than you are at the age of 3. There's never been a time in history, going back to Roman times, Tudor times, Second World War, that's been the case. And so our challenge as the next generation that take that baton is to face up to it and realise that it's a problem. So going back to your question, just to put that into context, going back to your question, part of it I think is about mindset. I think you can see from this conference that there's been a lot more talk about mental health compared to my first ever, I won't tell you when it was, my first RCPCH conference. That conversation has shifted. I think we've got a lot of new trainees coming through who are really switched on to this, and we are seeing a rapid increase in the number of paediatricians across the country who have an interest in this and recognise that will have to continue. The reality is these young people are always going to end up on wards. It doesn't matter how many people you've got in CAMS, there was always going to be a spillover into emergency departments. And generalists can't say no, can we? If a 28-weeker comes through the door, we have to sort them out. Whatever comes through the door, we have to sort it out. And, we chose general paediatrics, and so we have to deal with that. So it is our job. So, Elaine, you mentioned training. I think that's improved a little bit. I think it's important to think about what that training looks like. If that's a 1-hour webinar or an online course that you do on your night shift, that's not going to wash. So in some respects, it has to start right from the beginning, which is, I think, to some extent, is what's happening. I do think it's a bit of a shame that people seem to be in the wrong place. So sometimes, we're never going to have enough psychiatrists. We've already said that. Wonderful colleagues that you are. But we're never going to have enough of you. So the same way we're never going to have enough neonatologists, there are some generic skills that all paediatricians have in order to be a paediatrician, and managing risk and being able to look after and care for children and young people. So there's a bit about training, but I think that's a complex question, training, because it requires people to be interested, engaged, to want to learn. For me, everyone has to go on an APLS course. So why haven't we got a standard course on this, for example, if you think about the risk that's associated with it? Wards are still designed for under 5s. Wards have still got frozen pictures on the wall and Mickey Mouse in outpatients. Well, I'm not saying we shouldn't. I like that myself. But, that we do need to think about who are our clientele on wards and how we do that and deliver that safely in a managed way. But I also think it comes down to people who run hospitals and people who are commissioners, and doctors and nurses can say and stamp their feet as much as they like at 3 o'clock in the morning. The reality is, if you look at something like meningococcal disease or the management of trauma, it's all been done in a very organised way. We have debriefs, we have flow charts, we have practices, we have, from the minute you come through the ward, that golden hour. People have, over the last 30 years, have worked out how to do that. It needs to be embedded in what we do. Easier said than done.
Thank you, Lee. And Elaine, perhaps we could bring you in on this point, given your wealth of experience in thinking for the direction of travel, where we can bring that collaboration between the CAMS and psychiatry colleagues and the general paediatricians.
Absolutely, and just following on from what Lee is saying, it's about that whole system change. And I think as doctors we have a leadership role, but we're talking about the whole environment and where children and young people are turning up. And again, it's that idea of if you're looking for help in an acute crisis at 3 a.m, it's not going to go well. So what we're needing, as well as thinking about training and systems and pathways and protocols, are planned meetings. So just to give you an example, we know from feedback, people turning up with self-harm in A&E departments have traditionally told about the experience they've had, which is feeling like they're in the wrong place, they're not really sick, they shouldn't be wasting people's time. And if you think about what's driving self-harm and that low self-esteem and sense of hopelessness, it just reinforces it. And actually, clinically, we're going to get a much worse outcome. And what we were able to show in the Children's Hospital was you need the whole thing. You need people from the receptionist to all the clinical staff having training in how to look after young people who were coming in with self-harm. We developed a triage tool that was, amended from that being used for adults. We had a safe place for them to go. The staff knew that there was backup from specialist mental health services. So it's not like we think it should all be a paediatric task. But also we had regular planned meetings where we would be able to think about how it's working, how sometimes things really didn't go well and how we could improve things. We had training that was a 2-day training that included everyone from security staff to doctors and nurses, which really aimed at de-escalating situations, preventing restraints, preventing rapid tranquilization. And what was really gratifying was when we asked young people and families about their experience, it was universally positive. And that's a real shift, and I think that's where we're going for.
Yeah, that is a real shift. And it's great to hear an example of good practice. And thinking about feedback from young people, and I wonder what feedback you've received from young people who've been admitted to the general paediatric wards recently.
To be honest, a mixture. We've tried to gather as much feedback in as many different formats as possible from young people, and sometimes it's really difficult actually, because when's the right time to gather the feedback? Right there and then, or a few months later. But as some of the ways we've done it, in fact, Yeovil Hospital is sort of our sister hospital. They've got a really lovely way. They have a hard A4 book, notebook on their ward. And every time somebody leaves the ward after their admission, for whatever their admission is, they encourage young people to write a letter to the next person who's coming onto the ward. If you flick through this book, it's amazing. It gives you so much insight into what they've struggled with, what they found difficult. They're passing on the advice to the next patient. This is how I've got through it. This is what's helped me. And I think the overriding feedback which doesn't sit well, is a bit as you were describing, is the shame that they describe, this relational shame, that they shouldn't be there, that they're taking up our time, that there's other people more deserved of their admission to hospital. And that's really difficult as a paediatrician to hear and to know how we can help that and how we can turn that around, because they absolutely deserve to be on our wards.
Yeah.
A lot of them, most of them, I think, are on our wards because they've got a medical part of their illness that needs our care and needs our treatment.
Yeah. And have you got any examples of good practice or any innovative solutions that you've heard of that you think we could learn from?
I think there's some amazing examples of good practice around the country. I heard Isabel Paz, Oxford psychiatrist, talk the other day, and they've got a wonderful service in Oxford which is basically just fully integrated. Mm-hmm. So yes, it's about training, but I think the best way to get training is to work alongside people who have the skills, and this is what we should be aiming for, is a fully integrated service. So in Oxford, they've got an amazing paediatric psychological medicine service. Cambridge Hospital is obviously setting itself up to deliver the same. We're lucky enough in Taunton that our trust has merged, so that our acute mental health trust has merged with the hospital trust, and our leadership, both our clinical leadership and our executive leadership, is mental health and physical health. So, we have CAMS liaison on site, not just on site, on our paediatric ward, 6 whole-time equivalents working alongside us. They come to our handovers in the morning, they hear about all the patients that they might be able to help. I think eating disorders is probably a really good example of where this collaboration and integration works really effectively. So again, if we as paediatricians know exactly who might be coming into hospital, because we've had these discussions with our colleagues in CAMS, and we know that there are young people out there who are struggling and who might need admission, we can preempt that admission and we can plan for that admission. And we can work collaboratively with the family and the young people so they know what to expect. And that admission is, you know, as a paediatrician, you know what's expected of you, and you know your aims, and you know your goals, and you have a discharge plan. And that's always going to be far more effective than somebody arriving in crisis. And you don't know who to talk to, you don't know who to call. So I think the best practice that I can see is aiming for a fully integrated practice.
And they're not new concepts, are they?
No.
If you've got a child about to arrive in A&E, usually a phone call comes in from the ambulance on the way and lets you know that someone's arriving. If you know a patient with cystic fibrosis is going to be admitted electively for 2 weeks of antibiotics, usually the centre where you're sharing care, or a patient that's got febrile neutropenia, there's a shared care agreement and it's planned. That concept of planning, I think, is really important because, as you say, these things always happen Friday afternoon at 3:30 or at 3 o'clock in the morning. And we know when things aren't planned, that's where mistakes and problems happen.
Yeah, and could I just come back to the paediatric nurse? I think also there is a myth that young people would be so much better off on a psychiatric inpatient unit. And we know that, unfortunately, if you have a severe eating disorder and you do need to be admitted to a mental health unit, that often these stays are prolonged. It separates you from your family. You don't have that joined up physical and psychiatric review process, so it can be risky. But also the outcomes are not so good. So what we find is going to be, I think, much more hopeful is having that collaborative work around if there's a need for physical stabilisation in an acute health setting, and the development of really intensive community teams to support meal times, to support families, to get the evidence-based treatment going as early as possible.
And I'm seeing some good examples of practice from our audience. There seems to be a real key theme about availability of CAMS team and communication with CAMS team and psychologists. So having joint handovers involving the CAMS team, having regular meetings with everyone involved to improve that communication, and proactively having high intensity use personalised plans that are shared. And also taking Anna's point about having feedback from young people after their admission to catch up with progress. Lee, I wonder from your perspective what changes you've seen over the last few years, and looking to the future of the role of the general paediatric ward, what your hopes are.
Okay. So it's tempting to be doom and gloom about this, isn't it? And actually, I'm not actually a doom and gloom merchant. And I think actually there's lots of positive things. I think if we just start with mental health, we need to stop this narrative that having a mental health disorder is the worst thing you could possibly ever have. It's the worst thing you could have, because again, that adds to the stigma. Actually, there's lots of hope for people with mental health problems. There are really good evidence-based interventions. They've been around for a while. The problem, of course, is getting access to care to get those interventions. But I think what we all have to do, and I think people are shifting towards, is being a little bit more positive about this. And if you are needing to be admitted for safety, this is where you come for this, and this is what we do here for a bit. This is not making people feel guilty about using resource when actually that's what it should be there for. I think there's been a huge expansion in the number of paediatricians and people who have an interest in this. Partially that's because they've recognised that they've got no choice, because these people will keep coming. But also I think people recognise that this is an area to carve out and have a career in. When all of us on here have had careers out of this, because it is actually enjoyable, that you can actually make a difference. So I think that would be the main change, apart from the sheer numbers, which I'm hearing is settling slightly, because last year, and certainly during the first year of the pandemic, those numbers really peaked, as did CAMS referrals, but I think things are starting to settle down and get to be reasonable. It's never going to go back, I don't think.
We're going to go to some questions from the audience now.
Yes, so we've got a question that picks up on a point we mentioned earlier, thinking about what these general paediatric wards look like. And Lee touched upon, the fact that they are designed for perhaps our younger cohort. So Anna, if you wouldn't mind, can I come to you and ask you what facilities and what elements of the day-to-day structure of the ward can we adapt to support these young people?
We need to be asking the young people that question, don't we? I mean, that's the crux of it. We need to be, I think in paediatrics, we're nowhere near as good as our CAMS colleagues in inviting participation from the young people. CAMS do that really, really well. But hearing from them what they want. Because when I first started this job, I felt that we could deliver the best care if we separated these young people with mental health difficulties and we created a ward just for them within the paediatric environment, but I felt that was the best way we could deliver the care. But actually when I started talking to young people, what I was hearing really firmly back from them was, we don't want to be separated. We don't want to be put on the CAMHS ward. We want to be treated with the rest of the teenagers on the ward. And I think that's absolutely the right thing, going along the lines of integrated care is the right thing. So therefore we need to be thinking about, okay, how can we change that environment to suit their needs? I think it's almost impossible to deliver the best care to these young people if they are in a bay next to a 2-year-old who is there for their asthma. I think that's really, the rest of the hospital doesn't operate like that. We don't see people with dementia who've fractured their neck or femur being cared for in an ENT ward. And there's a reason for that, because you need a specific environment to meet their needs and a specific staff skill mix. So there's something definitely about the environment, but there's something also about the workforce, and that traditional workforce of paediatric nurses and doctors is not enough for this group of young people, and we need to be thinking outside the box, and we need to be thinking about youth workers and specialist OTs and social workers and family therapists joining us on the ward. So we need to be asking the young people first, what can we do better? And I think there'll be 2 answers, and it'll be about changing the environment, nicer curtains, nicer colours, soft furnishings, take the Mickey Mouse down, and also changing our workforce.
Thank you. And I know that is really difficult when you're confronted with a lot of young people who are really sick, whether it's with physical or mental health presentations, not to maybe find it overwhelming, but it would be fantastic if they at least got that message, the individual child in front of you got the message that they've come to the right place. Now that might be in the context of feverish activity going on behind, talking about setting up services, pathways, training, but just that they get that positive welcome from everybody. But also thinking about the environment, I think we've a lot to do in both psychiatric and paediatric settings, thinking about the most vulnerable children. And we know that those who get most stuck, for example, with self-harm and eating disorder, often have neurodevelopmental vulnerabilities. And our environments are pretty hideous when it comes to that. Supersaturated colours, highly noisy, and actually add to that distress. So it's about how can we think about being able to deliver proper clinical care, but have the environment, like hearing the feedback from young people about what it is that makes them feel much calmer, much more grounded and contained, and much more able to cope.
Did you know there's not one published paper in the world on young people's view as actually someone studied young people in these contexts? Not one.
There's your next paper.
So it'll probably be part of MAPS, hopefully, but there isn't. That's where we're at with the literature on this as well.
It's crazy, isn't it? So we'd like to, at this point, throw it open to our audience. So if anyone would like to come up, we've got 2 mics either side of the stage. If anyone's got a question, could we perhaps invite one person to come up and ask it to our panel?
Hi, my name is Philip. I'm one of the pediatric trainees. My question is based on my experience while working as a pediatrician during my 2nd year. So we had this child who had spent up to 1 year on the ward because we couldn't get the child to go to the appropriate place for his mental health care needs. And he's known to be physically abusive. While working this morning, I was faced to the computer with my back against him, and I incidentally heard a loud bang in form of a punch at my back. It caught me unaware, so I was really shocked, and as human, you definitely want to defend yourself. But I just thought again that I don't think it was his fault, and he definitely didn't do this deliberately. So when I spoke to my team that morning, they all advised that I do a day 6 about it, but I just felt this wouldn't do enough justice. And as we know, most times, I don't know if most of the data has been collected about what we get from our day 6ing. So I just decided to ask the team what they would do in this kind of scenario if they were me. Thank you.
I think the first thing is it's really important that we get much more systematic about documenting when this happens. So actually using daytext can be a very powerful tool. And also what we don't know, I don't know that we're systematically collecting information about the number of time young people are restrained in paediatric settings. And I think that's a really crucial piece of information, because clinically what we would say is that where you have staff that are trained, where they understand developmentally what the children's vulnerabilities might be, how to approach them, how to de-escalate the situation, the number of restraints are much, much rarer. So first, it's about let's find out what the problem is and then get in there with training, support and supervision. But no one should ever feel bad about feeling the need to be safe at work. Nobody comes to work to be hurt. We may understand that all behaviour is a communication and it's usually about a child in distress. But the more we actually work on this, and as Lee was saying before, let's get much more systematic about this. We do that for physical healthcare conditions. Let's move on to mental health care conditions in the same way.
Thank you for that response. We're nearing the end of this workshop, so I'd like to know from everyone in the audience and our panellists what their take-home messages are when considering the role of the paediatric ward in caring for young people with mental health presentations. So Lee, if I start with yourself.
You know what I'm going to say? We need more data, and because the way you change things is a need, but also data, and also patient young people's voice. Patients' voices are so powerful these days, and should be. So it's really about how do you affect change. I think it's working with young people and parents who've had that experience and not forgetting about it, and off they go after debriefing and where that went wrong. But also data, so you can make the arguments about the importance. Because at the moment everyone's saying it's a problem, but no one's really writing it down.
Anna, what's your take-home message or call to action?
My take-home message is, as Leah said, it's not going to go away. This is contemporary paediatrics as we know it, so we need to embrace it. And I think the best way to do that for us as paediatricians is to be making friends with our CAMHS colleagues and literally knock on the door, invite them out for a dog walk, invite them to a barbecue, get to know them as people, because it makes it easier when you've got to pick up the phone and have a discussion about somebody. And as much as we can, we need to be supporting our paediatricians and their job plans to give them time to do that, to give them time to potentially go off-site, because a lot of CAMHS bases aren't, physically in the same area, to be able to upskill themselves and form those relationships and form the collaboration that we're going to need in order to be able to embrace the change that's needed.
Thank you. And Elaine, what's your take-home message?
I think Anna said it all, actually. I think it's so much about collaboration, but also I feel very hopeful about the lead role for paediatric mental health that has been really pushed so effectively through the college and with NHS England, because it has to be job planned. This is not a hobby. You know that people working in community CAMHS have been besieged with referrals, so it's going to be very difficult to get their attention and their focus when they are dealing with all these kind of crises in the communities. I do think chocolate always works, but I think you're right. I think what I would really love to see would be paediatric and CAMHS colleagues having each other's mobile numbers, and it's not to be bothering each other in the middle of the night, but that idea that you get to know each other enough, because we need your support as well with the physical health care of some very complex children. But collaboration, and someone was suggesting joint training. I mean, face-to-face training in the room is so different to doing an online module at home. I just think getting in the same room and sharing best practice and learning from each other is the way forward.
Thank you. And we've had some answers from the audience. So it says that person is optimistic to see that other peers have seen what they've struggled with, and this idea that they can change it together. And joint training, and also joint supervision.
Or supervision full stop for paediatricians.
Yeah, absolutely.
Again, something we don't do very well, and it's definitely needed.
Yeah. Leila, as a trainee, what's your take-home message?
So I think it's that direction of change for the future, and actually the conversations that we're having not only today but in the ward and amongst junior colleagues. Actually, I think we're using different language. We are, thinking about the young person's journey. They're delivering trauma-informed care, I think, is something that has been introduced to me from such an early stage that actually I'm excited to think about how I can incorporate that to every stage of my practice.
Thank you. And to move on now then, so our panel have suggested some resources which will be available in the podcast show notes. We end every podcast by asking our panel for their book recommendations. So Anna chose The Shock of the Fall by Nathan Filer. Elaine chose The Body Keeps the Score by Bessel van der Kolk, and Lee chose Wolf Hall by Hilary Mantel. Thank you so much to Dr. Elaine Lockhart, Dr. Anna Kyle, and Dr. Lee Hudson for joining us today. And thank you all for listening. We hope you enjoy the rest of your day.
That's all for this episode. As always, if you have any questions or comments, please feel free to get in touch via our email address podcast@paedshub.co.uk or via the PaedsHub website. Equally, if you'd like to get involved, we always welcome your voices, so please do get in touch. Thanks for listening.